Hello and welcome to Symposium 7, entitled Clinical Uncertainties A. I'm Julie Dombrowski from the University of Washington and Public Health Seattle-King County, and I'm very pleased to be co-moderating today's session with Dr. Jody Dion Odom from the University of Alabama at Birmingham. Our first talk is Metronidazole Allergic Patients with Trichomonas by Dr. Christina Musney. Dr. Christina Musney is an associate professor of medicine in the Division of Infectious Diseases at the University of Alabama at Birmingham, with a secondary appointment in epidemiology. She obtained her medical degree at the Texas A&M University Health Sciences Center College of Medicine, and subsequently completed internal medicine residency and an ID fellowship at the University of Mississippi, prior to joining UAB faculty in 2010. Her clinical and research interests focus on the pathogenesis, epidemiology, diagnosis, and treatment of vaginal infections, including BV and Trichomonas. She's participated in multiple clinical trials regarding Trichomonas treatment and is R1 funded to study BV pathogenesis.
Thank you so much, Julie, for that introduction, and thank you to the planning committee for giving me the opportunity to talk about this topic today. So as Julie mentioned, my topic is metronidazole allergic patients with Trichomonas infection. This is my disclosures. And the outline for this presentation today, I wanted to start off with a brief overview of updates in the epidemiology, clinical consequences, diagnosis, and treatment of Trichomonas, and then spend the majority of the presentation talking about allergy to 5-nitroimidazoles, which includes metronidazole that we frequently use, and then what to do for these difficult to treat patients in the setting of this allergy. We'll talk a little bit about desensitization and then some alternative intravaginal and oral therapies that may be available, and then talk about next steps for these kinds of patients. So just to briefly review the epidemiology of Trichomonas, about 2 years ago now, some recent NHANES data was published in Clinical Infectious Disease Journal, which looked at U.S. national prevalence of Trichomonas in women and men. This is actually the first time the prevalence in men was documented, and patients in this study were tested by a nucleic acid amplification test ran on urine specimens. In this study, they found that the prevalence was 1.8% among women and 0.5% among men. And please note, these were ages 18 to 59 in this study. There was a pronounced racial disparity with regards to Trichomonas infection, particularly in African-American females, where the prevalence was up to 8.9%. Other risk factors are older age, female sex, less than a high school education, living below the poverty level, and having greater than or equal to 2 sex partners in the past year. The burden of disease for Trichomonas in this study is found to exceed estimates of this infection in other high-income countries such as the United Kingdom. Several years ago now, we had the opportunity to look at the prevalence of Trichomonas at our own health department clinic here in Birmingham. This is a busy STD clinic at the Jefferson County Department of Health. They actually started screening all women and men who come to the clinic with a nucleic acid amplification test in 2012, and we were able to review these patients' records for the first year of this practice. We found the overall prevalence of Trichomonas at this clinic to be 20%, so very high. And in women, it was 27%, and men, 9.8%. We do think that the lower prevalence of Trichomonas in men at this clinic is perhaps partially due to spontaneous resolution of this infection that is known to occur in men. Another important caveat about this study was that the nucleic acid amplification test detected a third more Trichomonas infections in women than if wet mount alone had been performed. With regards to consequences of untreated Trichomonas infection, I have it here listed for women and men. And women particularly can cause vaginitis, cervicitis, and endometritis. It's known to be associated with adverse birth outcomes and other reproductive health outcomes, and it is known to be associated with an increased risk of HIV acquisition. With regards to men, it is associated with urethritis, penile discharge and dysuria, and also an increased risk of HIV acquisition. There is some debate in the literature about whether or not Trichomonas can cause prostate cancer, and I think that is not 100% clear at this point, and it's something to be looking forward in future research moving ahead. With regards to diagnosis, there's been an explosion of diagnostic tests for Trichomonas over the past 5 to 8 years, and we summarized them in some of our recent papers, one of which I have listed at the bottom of the slide if you're interested in reading about it. But I've split them here into 2 slides of point of care tests and then non-point of care tests. And of course, wet mount microscopy is the most common test that has been used traditionally for Trichomonas. We also have the AWESOME test now, which is a rapid antigen detection test, and then several molecular diagnostic point of care tests that have become available over the past several years that I have listed on this slide. With regards to non-point of care tests, culture has traditionally been the gold standard for Trichomonas diagnosis. It does require that you have access to an incubator, and also the Trichomonas in-pouch culture has to be read over a 5 to 7 day time period, so it takes a while to get your results. And so recently we have this explosion, as I mentioned, of lots of molecular diagnostic tests, many of which I have listed here on this slide, that have much higher sensitivity and specificity than culture and wet mount for Trichomonas diagnosis. So I'm going to spend the rest of the talk talking about treatment. So I just wanted to review the current treatment recommendations for Trichomonas. This is based on the 2015 CDC Std Treatment Guidelines. Currently, metronidazole, a 2-gram stat dose, or tinidazole, a 2-gram stat oral dose are the recommended regimens, with the alternative regimen being 500 milligrams twice a day for 7 days of oral metronidazole. However, please note that this 7-day regimen is the preferred regimen for HIV-positive women. And that is because there was a randomized controlled trial done almost a decade ago now in 2010, published, of HIV-positive women that had a head-to-head comparison of the 2-gram stat dose versus the 7-day dose, and found that the 7-day dose was more highly efficacious in HIV-positive women. We actually had the opportunity to perform a similar trial to that, and with our results published a couple years ago now in 2018, where we did a similar trial in HIV-negative women. And again, we found that the 7-day metronidazole dose is more highly effective in HIV-negative women than the 2-gram stat dose. So it's highly likely that moving forward in updated guidelines, the 7-day metronidazole dose is going to be the first-line recommended dose for all women. And actually, ACOG has already made this switch in their updated 2020 guidelines, which I have on the bottom of this slide, where they do mention that the 7-day dose is the preferred regimen for Trichomonas infection in women. And so this leads me into just mentioning this 5-nitroimidazole class of medications, of which metronidazole and tinidazole are part of. There's also a third agent in this class called signidazole, which is coming down the pipeline for potential treatment of trichomoniasis among patients in the United States. There's a clinical trial with results about to be published on that. But with regards to all 3 of these medications, they're all very similar structurally. The only difference really is that they differ in the groups that are attached to the ring nitrogen adjacent to the nitro group in their background chemical structure. But usually if you have an allergy to one of these medications, you're very likely to have an allergy to other medications in this class because they are all so structurally similar. So this brings me into hypersensitivity to 5-nitroimidazoles. And this has been recorded in the literature to have type 1, type 2, and type 4 hypersensitivity reactions, particularly to metronidazole. That's the drug that most case reports are published about. And so how do you manage these patients? So basically, the first step is you have to determine, is this a real allergy? And is the history that the patient's giving you or the data that you have in their chart supportive of an allergy? And particularly red flags that can make you think that this is a real allergy is history of urticaria after taking the drug, a severe rash, itchiness, vasodilation, flushing, bronchospasm, If the patient mentions they had been intubated before after taking one of these medications, all of those are red flags that their allergy is actually real. So the second step, if you determine that this is a real allergy, you would want to consult an allergy immunology specialist to see if your patient can be considered for oral or IV desensitization to metronidazole. I'm not aware right now of any published desensitization regimens for tinidazole. The ones that I have found in the literature have all been about metronidazole, and I have those listed here in a few slides. I just wanted to talk about them briefly. The first desensitization protocol for metronidazole was an oral protocol, which came out of UCLA in 1991. It's called the Kuro-Hara protocol, which I have listed here on this slide. And one of the limitations about this protocol is that they did not mention in their paper the dosage time interval between each of these successive doses. And also, you can see on this slide, towards the end of the protocol, they go from a 250 milligram dose to a 750 milligram dose, which is kind of a big jump. And the one patient that they had used this protocol on in their paper had an allergic reaction when they increased up to the 750 milligram dose. And so basically, others have argued that the oral metronidazole desensitization protocol needs a more gradual dose escalation than what is listed here. The next protocol that was published was in 1996. This is the Perlman Protocol, which is the IV protocol that typically has to be done in an ICU setting or in the hospital. And this one has a more gradual dose escalation of IV metronidazole. And this protocol, each dose is given every 15 to 20 minutes while the patients are monitored. They initially published 2 patients with this protocol, and actually both of the patients had reactions during the protocol, some itching and shortness of breath, and they mainly occurred at the 25 milligram and 100 milligram dosages, and they were able to treat through that with IV Benadryl and famotidine, which is an H2 blocker, and get both of the patients through that to where they successfully completed this protocol and were able to be desensitized. Finally, more recently in 2014, a group published a modified oral protocol, which has this more gradual oral dose escalation. And so this protocol has been successful with no issues in the patients that they tested it on in the clinics. So with regards to 5 hypersensitivity reactions in women with trichomonas, majority of papers are either case reports or case series. The largest case series is actually published by the CDC in 2008. And they actually had 3 years of data that they published. It was actually from 2003 to 2006. And they had approximately 129 patients. They had providers call from around the country on 129 patients that were having these metronidazole hypersensitivity reactions. And they were calling the CDC for assistance in how to treat these patients. When they reviewed their records, they only had complete data on 59 of these patients. And I'm not going to go through this whole flow chart because it'll take a long time, but I thought it was interesting. Out of this group of patients, they had 15 that they actually recommended oral or IV desensitization. And this was 100% successful for all of these patients for both the IV and the oral regimen, which is a good sign. However, for the people that were not eligible for desensitization, which usually the allergist decides if they are or not recommended for desensitization, they had tried some intravaginal anecdotal treatment options, which 12 patients got these and only 41.7% of them may be cured. So this is an important point as I move on in this presentation, that if the best thing to try to do is try to do desensitization, but if you can't for some reason or the patient can't tolerate it, we have to move into these intravaginal therapies, which have a lot of limitations and difficulties. And here you can see in the CDC series, they use betadine douches, intravaginal perimycin cream, clotrimazole intravaginal, and intravaginal furazolidone. So there's a lot of limitations of these intravaginal therapies I have listed here. One of the major limitations is that because they're just administered locally in the vaginal canal, they may not reach all sites infected with Trichomonas. And so patients may initially get better symptomatically, but they may later have an increase in their symptoms again because some of these sites that aren't being reached by the medication are contributing to persistent infection. The majority of these intravaginal medications have to be formulated at a compounding pharmacy, and they are more expensive than metronidazole, which actually metronidazole is the cheapest medication that we have for any STD. So there definitely is a cost issue here. They also require a prolonged course of therapy, many of them for up to 2 months. Some of them have been used for up to 5 months, and clearly patient compliance with this could be an issue. And also some of them have some pretty significant adverse effects, such as vaginal ulceration with Perlman cream that has to be taken into consideration. So I originally got interested in this topic when I was a fellow 10 years ago now. I had a patient that had a severe hypersensitivity reaction. My allergist, I had 2 allergists actually try to see her, and they both said she was not a candidate for desensitization. So I had to figure out what to treat her with. I had done a literature review at the time on this topic. In addition to the CDC case series that I just talked about, there's also a few small case reports on this topic by providers all over the world. And I have these listed here in this chart that we published a couple years ago in the STI journal. So I had found in 2 Canadian reports the use of intravaginal boric acid. And then also some other people had tried the intravaginal furazolidone. One group had tried the boric acid alternating nightly with intravaginal clotrimazole, and then the Perlman cream, and then these betadine douches. These are all just simply case reports, but the majority of these had good cures, except this one here, the intravaginal Perlman cream. This paper was published by Paul Nirogesi and his group, and they had 6 out of their 9 patients that got cured with the Perlman cream in this study. So not 100% cure rate in this study. Also, I didn't put in this chart, but there's some case reports on oral nitazoxanide, which is an antiparasitic drug used for cryptosporidium infection. And this had been tried for trichomonas infection, but patients did not do well on that drug. They were not able to be cured, mainly because it's not absorbed systemically, and they weren't getting poor penetration to the vaginal area. So with regards to boric acid, I ended up using that twice in 2 of these difficult to treat patients. After reading the Canadian case reports, that those patients did not seem to have significant adverse side effects with boric acid. And so I'll talk about those 2 patients in just 1 second. But someone did an updated literature review on the use of boric acid in patients with trichomonas that was published just 2 years ago now. So there has been 4 patients published in the literature in addition to these Canadian patients. These cases here, I think, are only in the United States. But these 4 patients all had successful microbiological and clinical cure from using intravaginal boric acid. And so the first patient and the 4th patient are actually my 2 patients that we've seen in various clinics. Those patients were cured with 60 days of 600 milligrams twice a day of boric acid. But the other patients, people have used up to 5 months of boric acid. And then here, this 3rd patient got boric acid twice a day for a month, alternating with intravaginal gentian violet once weekly. So there's a lot of voodoo with the regimens for these medications, including boric acid. So the only ones I can personally speak to is the 60-day twice daily dose. So we published those 2 patients. One was in 2012 and one was in 2017. And the big point about these 2 patients that we successfully treated with boric acid is that they both had been on multiple regimens of other intravaginal medications before we just tried to use boric acid. And both of these patients had come to me from other providers who had already been seeing these patients, and I had been recommending to them over the phone some of these treatments. And so it kind of goes to show that these patients have a very difficult clinical course that can be hard and frustrating trying to get rid of this infection, particularly if desensitization cannot be performed, which was the case for both of these patients. But we were able to successfully cure them with the 2 months of boric acid. And what is the potential mechanism of action of boric acid? When I looked into this in the literature, it's thought to create a more acidic vaginal environment that it activates factors that contribute to T. vaginalis pathogenicity, such as cell detaching factor, which is acid labile. So that's thought to be the mechanism. And the last thing I want to talk about really quickly is next steps. In this situation, clearly we need more drugs for Trichomonas outside of the 5-nitroimidazole class of medications that are potentially oral drugs to not have to deal with all these issues with the intravaginal medications that I've been talking about. So I recently became aware of this drug called Aranophen, actually from Evan Secor at the CDC, who heads the malaria and parasitic laboratory there. There is some in vitro data and mouse model data about this medication treating Trichomonas infection. It's actually FDA approved in this country since 1985 as an anti-rheumatic drug to treat rheumatoid arthritis, psoriasis, and pemphigus, and it's partially composed of gold particles, this drug has recently been labeled for the treatment of parasitic infections. And the mechanism of action of this drug is that it inactivates thioreduxin reductase enzyme, which is involved in one of the metabolic pathways of Trichomonas vaginalis. And this may lead to altering that metabolic pathway and causing cell death of the parasite. It has had some success in vitro and in this mouse model study, and Evan Secor keeps telling me we need to consider trying to use this medication in patients to see, in a clinical trial setting, to see if it could be a new drug class of oral medicine to treat Trichomonas infection. So I definitely think this is something we can look at on the horizon. These are my acknowledgments for all of the teams that I work with in my research. And then my email address is listed on the end of this slide. If anyone wants to contact me separately with any questions or any patients that you have difficulty treating, or even to know your experiences in this field would be wonderful, because this is an evolving field. It's very difficult to treat these patients. Thank you so much.
Great. Thank you very much for that excellent talk, Christina. Our next talk is by Dr. William Geisler, and the title of his talk is Treating Resistant Mycoplasma Genitalium. Dr. Geisler is a professor of medicine and epidemiology in the Division of Infectious Diseases at UAB. He has established chlamydia and MGen research programs. He has over 20 years of clinical experience in the evaluation and management of STIs and provides STI education and training through the Alabama, North Carolina STD HIV Prevention Training Center. He is on the editorial board of Sexually Transmitted Diseases and has served as an expert consultant for the CDC and WHO. He's also the co-director of the UAB Medical Scientist Training Program. Welcome, Dr. Geisler.
Thank you so much for the introduction. I want to thank, again, for being invited to give this presentation today. And my disclosures are listed here. So before talking about specifically treating resistant Mycoplasma genitalium infections, which I've abbreviated in my slides here as MG for Mycoplasma genitalium, I want to talk just very briefly about the justification for treating M. genitalium and what the first-line treatments are for treating M. genitalium. So we treat M. genitalium for symptomatic relief because it can cause symptomatic urethritis and cervicitis. We also treat M. genitalium to try to prevent complications. There's moderate evidence that M. genitalium causes pelvic inflammatory disease, and there's some more limited evidence that M. genitalium infection is associated with infertility and adverse pregnancy outcomes. We also treat M. genitalium with hopes of decreasing HIV acquisition risk. There's pretty strong evidence based on a meta-analysis that M. genitalium infection can increase one's risk for getting HIV. There are several drug classes with in vitro activity against mycoplasmas that are listed on the slide here, and they really fall into having one of two mechanisms of actions. And so the drug class quinolones, they basically inhibit M. genitalium by inhibiting bacterial nucleic acid synthesis. And moxifloxacin is the quinolone in the U.S. that has the most potent activity against M. genitalium. And then the other classes all work by inhibiting bacterial protein synthesis, and that includes your macrolides, ketolides, streptogramins, aminoglycosides, tetracyclines, and plurimutilins. Now, the three drug classes I've highlighted in blue on this slide are the ones that we have available to treat patients in the U.S., and we have good data for treating patients. So those are considered the kind of the first-line drugs. So that's your moxifloxacin, your azithromycin, and your doxycycline. So let's just talk about how well do these first-line drugs work. Well, some of the best data, I think, looking at doxycycline has come from three different randomized controlled urethritis treatment trials, where if you look at men that had M. genitalium urethritis, doxycycline only cured anywhere from about 30 to 45% of the M. genitalium urethral infections in these men. And what's interesting about doxycycline, it's not really understood why it doesn't work that well for M. genitalium, because there's been no demonstrated mechanism of resistance for M. genitalium to doxycycline. Now, azithromycin 1 gram, which is one of the other kind of first-line treatments for M. genitalium, historically it used to work quite well. And that was shown here in this earlier urethritis treatment trial, where about 87% of men with M. genitalium urethritis recur with azithromycin 1 gram. But you can see over two subsequent urethritis treatment trials that the azithromycin cure rate for urogenital M. genitalium dropped down to 40%. And if you look at subsequent studies, not just clinical trials, but just really any treatment studies that have looked at data for azithromycin 1 gram treating urogenital M. genitalium infection, you see that for studies that were conducted prior to 2009, the pool cure rate was about 85% for azithromycin 1 gram for M. genitalium. But studies that were conducted after 2008, the pool cure rate's about 67% for azithromycin for treating M. genitalium. And so there's been a steady decline in the efficacy of azithromycin for M. genitalium, and this is pretty much this is pretty much due to resistance of M. genitalium to macrolides. And so we know that there is a gene mutation in the 23S rRNA gene of M. genitalium, and the presence of that gene mutation it strongly correlates with treatment failure when using azithromycin to treat M. genitalium. And if you look at how frequent is this gene mutation for macrolide resistance in M. genitalium strains in the U.S., you see in this map I'm showing you here that it ranges anywhere from about 44% to 90% of all the M. genitalium strains that have been tested have this macrolide resistance mutation. And the highest frequency of this mutation is found amongst men who have sex with men. But the point being that about half or more of all the M. genitalium infections that have been studied for resistance mutations in macrolides have the resistant mutation. So macrolides are really no longer a great first-line treatment for M. genitalium. So that really only leaves us with moxifloxacin as one of the other first-line M. genitalium treatments in the U.S. that we have data for treating M. genitalium. If you look at studies that were done particularly before 2013, you see that moxifloxacin cured all or most of the M. genitalium infections given at a 7, 10, or 14-day treatment course. But then in 2013 and since then, we started to see studies published where the cure rates for moxifloxacin against M. genitalium range from the 60s to 80s percentile range. And so that's quite concerning about the emergence of these lower cure rates with moxifloxacin against M. genitalium. And why have the cure rates been dropping? Well, we think, again, it's probably because of resistance. However, unlike macrolides, where we know that if you have that macrolide resistance mutation I discussed, that you have a high treatment failure rate, it's not so clear with quinolone resistance. So it turns out that not all the mutations that one finds in the quinolone resistance determining region for M. genitalium are associated with treatment failure. There's really only one that most studies have shown is the most strongly associated with moxifloxacin treatment failure, and that's a mutation in the PARC gene called S83I. But again, not every study that's looked at that one specific mutation has shown an association with treatment failure. The prevalence of that one PARC mutation, by the way, across two different studies in the U.S. ranged from 6% to about 30%, with the highest mutation rate amongst men who have sex with men. And typically in individuals who have failed moxifloxacin and who you find that PAR-C mutation, you also detect the macrolide resistance mutation as well. So there are multi-drug resistant strains. So there's been a new strategy proposed. It's in the Australian and UK M. genitalium treatment guidelines. I suspect something like this will be also in the upcoming CDC treatment guidelines. And this is a sequential therapy strategy to limit the likelihood of developing resistance for our first-line drugs against M. genitalium and improving cure rates. And it's a fairly simple strategy. It's called sequential therapy. And the way that it works is for a patient that has proven or suspected M. genitalium, you start them out with a 7-day treatment course of doxycycline with the primary purpose to lower the M. genitalium bacterial load. And then after those 7 days of doxycycline, you come in and treat them with either an extended course of azithromycin or a course of moxifloxacin. And which of those two that you choose, ideally is going to be based off of testing for that macrolide resistance gene. That testing, which is readily available outside of the US, is not readily available in the US. There's only a few labs in the country that can do that. Mine is actually one of those labs. So it's not clear exactly in the US if you might go straight to moxifloxacin and not use the azithromycin option. But studies have shown that by doing the sequential strategy, you can lower the bacterial load prior to starting azithromycin or moxifloxacin, and then you'll have a lower likelihood of developing resistance once you start that second line of treatment. But basically, for patients who have failed doxycycline, azithromycin, and moxifloxacin for M. genitalium, we call those resistant M. genitalium infections, and that they're treatment resistant. And some basic considerations before you just give them another drug that you should do is first address adherence with the treatment and also any possible re-exposures. So if a patient was not adherent with a previous M. genitalium treatment or was just re-exposed to an untreated partner, then rather than moving to another treatment regimen, simply retreat them with a previous regimen and get the partner treated. You should also confirm that they still have M. genitalium detected before you continue to add additional treatments. And I say that because we clearly see patients who had M. genitalium who we've cured microbiologically based on repeat testing, but they seem to have lingering symptoms even though you cannot detect M. genitalium. And in my own experience in treating those patients, if you just keep giving them antibiotics for their symptoms, but you don't detect M. genitalium, their symptoms, at least in the short run, tend not to get better with these repeated antibiotic treatment courses. And we don't understand why they kind of have these lingering symptoms. The other thing I just say is that you cannot get the crinoline resistance mutation commercially in the US. My lab can actually do it, but even though we can do it, it's really of limited use for treating, for at least using it for treatment decisions about M. genitalium. And that's primarily because of that lack of consistent correlation between finding an M. genitalium resistance mutation and treatment failure. I've had a fair amount of anecdotal experience in treating resistant M. genitalium infections. I think that's in part because I publish papers and patients get my name and then they just email me directly about this. But I just want to share briefly my own anecdotal experience before I got into the treatments. So most of these cases of resistant M. genitalium infections I've seen are men with symptomatic urethritis. And their infection persists for usually months, sometimes over a year, despite getting some of these first-line treatments. When my lab has done testing for resistant mutations in these men, all of them have had a macrolide resistance mutation. All of them have had at least one crinoline resistance mutation, though not all those crinoline resistance mutations have been the PAR-C S83I. It's really interesting. Actually, the partners are usually M. genitalium negative, either initially or you treat them with, say, a first-line drug, and they clear their M. genitalium even though the patient seems to have persistent infection. And that's also not understood why that happens. I've learned that usually if a patient's already failed a course of moxifloxacin and there's no issues with non-adherence, then repeating a course of moxifloxacin is usually not effective in those patients. Because I get that question a lot. That's why I mentioned this. And then I've also learned that sometimes M. genitalium infection can spontaneously resolve. We've had some patients that have failed first-line treatments, and by the time that we finally were able to get them one of the salvage regimens, their infection actually just kind of cleared on its own. So these infections will eventually clear, at least some of them. But what are you going to do, at least, again, if they fail these first-line treatments? Well, in the U.S., you've got mainly 3 options. These are all off-label salvage options for treating M. genitalium, and they are minocycline, amanocycline, and lefamulin. And so let's briefly go through these three. So minocycline is a tetracycline antibiotic. It's an older antibiotic, so we've had it for a while. And our group and another group in Japan have both published case series where we've shown that treating with 14 days of minocycline has cured patients who had failed these other first-line drugs. And these were men with urethritis, by the way. It's a generic antibiotic. It's very affordable, less than $25 out-of-pocket cost if you use a good RX coupon. But unlike doxycycline, which has mostly just GI side effects and some photosensitivity, minocycline has some other bothersome side effects we sometimes see, including complaints of numbness, burning pain, dizziness, muscle or joint pains. And so that's just something that I'm telling you about that you might see that you're not used to seeing with doxycycline. But this is basically my kind of go-to first-line drug after patients have failed doxycycline, azithromycin, and moxifloxacin. Now, amanocycline is a fairly new tetracycline antibiotic. Just became approved in 2018 for treating skin infections and pneumonia. It's dosed once a day. There's no published in vitro data for its activity against M. genitalium, even though our group actually has some unpublished data showing that the amanocycline MICs are a little bit lower than doxycycline or minocycline MICs against the drug-resistant strains that we've tested. So that is promising. There's no published data for treating humans with M. genitalium infection with amanocycline. And it's also a very expensive antibiotic. Last time I checked, over $3,000 wholesale cost for 7-day treatment. But it is well tolerated if you choose to try this antibiotic. Now, lefamulin is from a drug class called pleuromucilin, and it was FDA approved in 2019 for treating community-acquired bacterial pneumonia. It's dosed twice a day. There is published in vitro data which shows it has very good in vitro activity against M. genitalium, including the drug-resistant strains. But to my knowledge, there's no published or anecdotal data treating patients with M. genitalium with lefamulin. I've got a couple of patients actually right now that I'm following that are taking it. So maybe I'll be able to report back to you how those two patients do. The drug has side effects, however, that's similar to azithromycin, including that rare potential to prolong QT interval. And I think that other than not having published data on its efficacy, the other big limitation is that it's very expensive. Again, over $2,000 wholesale cost for a 7-day treatment course last time I checked. So then what are you going to do? Let's say you have a patient in the U.S., you've tried minocycline, it didn't work. You maybe tried lefamulin or amanocycline, and those didn't work, but you still detect M. genitalium. Then what are you going to do? Well, outside the U.S., there are at least three drugs to my knowledge that are available: priscinomycin, citalfloxacin, and spectinomycin. I'm going to talk a little bit about priscinomycin in my next slide because that's one that you can potentially import to the U.S. So we'll talk more about that in a minute. Citalfloxacin is a fluoroquinolone. It's made by a company in Japan. It actually looks like it might be a little bit more effective against M. genitalium than moxifloxacin, but I don't know of a way that you can actually get it into the U.S., so that is a limitation. Spectinomycin is an aminoglycoside that you have to give by intramuscular route, and it doesn't work all that well. So for both of those reasons, I would not consider that one that you would try to import into the U.S. But priscinomycin, if you look at its data, it's an antibiotic from the drug class streptogrammin. It has two different components that I've listed here. It has published in vitro activity that looks good against macrolide-sensitive strains. However, there's no published in vitro data that I've seen with its activity in vitro against macrolide-resistant strains of M. genitalium. There's been a few different studies published looking at its efficacy for patients who have failed other first-line drugs for treating M. genitalium. The most recent one and the largest one was published in 2018 by Reed and colleagues, where they showed that there were 114 M. genitalium cases treated with priscinomycin, and the cure rate was 75%. So it's not a super high cure rate, but that's a pretty good cure rate as a salvage treatment regimen, and the antibiotic was tolerated quite well. Now, I do have experience in using priscinomycin because we imported it into the U.S. for a patient that we were treating who was immunocompromised and was at major risk for life-threatening infection due to M. genitalium. And so we had pretty strong justification about why we needed to import this drug. So what we basically did is outline in the slide here. We had to contact the company that makes priscinomycin, who is Sanofi out of France. We had to get an agreement letter from them that they would provide the antibiotic for our patient. Then we had to complete an FDA form 3926, which is a patient expanded access IND, to get approval. We had to get local IRB approval, including having a written consent that the patient had to sign to take the drug. And then we also had to provide a letter for U.S. Customs so that when the drug goes through U.S. Customs, they know why it's coming into the country. So then the drug basically ships into your country to your airport, and then it's delivered to your clinical site. This is a complicated process, but we were able to accomplish this in about 3 weeks for our patient. And again, I don't think every single healthy patient that you want to treat with priscinomycin that the FDA is probably going to grant that, because I'm getting called about a lot of these patients. But I think if you have somebody with more complicated disease from M. genitalium, or particularly who's immunocompromised, that's probably a stronger justification to pursue this route. So let me just, my last slide here, or second to last slide, summarize my key take-home points are that treating resistant M. genitalium is challenging. And that's primarily because we have limited other M. genitalium treatment options available, particularly in the U.S. In the U.S., I would suggest trying minocycline for patients who have failed azithromycin, doxycycline, and moxifloxacin, and that's assuming that you've proven that they still have M. genitalium detected. If you fail minocycline, I would probably then try lefamulin, even though we don't have any published data in humans with it. It does have good in vitro activity, but just realize it's unproven efficacy in humans. If that fails, you can try amanocycline. Though there's no data at all on using amanocycline. You can try importing priscinomycin, but I talked about how complicated that process can be. And I just want to remind you in closing that when you're evaluating a patient with suspected M. genitalium treatment failure to first-line drugs, please make sure that you address treatment adherence and re-exposure to untreated partners, because that's more common than sometimes you think. And that's a simple fix in terms of retreating patients with first-line drugs. And when you repeat that M. genitalium NAT, please wait at least 2 or more weeks after you finish the treatment, ideally, so that you don't run the risk of a false positive NAT test from testing too early. And I thank you for listening to my presentation today. If you have any questions, please contact me in my email that's listed here. Thank you.
I am very pleased to introduce for you Dr. Christine Johnson, who's going to talk about the role of Hsv Serologies. Dr. Johnston is an associate professor in the Division of Allergy and Infectious Diseases in the Department of Medicine at the University of Washington. She's an infectious diseases physician who performs clinical studies of genital HSV infection, focusing on the interaction between viral pathogenesis and host immune responses, with the ultimate goal of developing successful vaccines and medications to prevent and treat HSV infections. In addition, she's the medical director of the University of Washington STD Prevention Training Center, which is part of the CDC-funded national network of STD clinical prevention training centers. Take it away, Dr. Johnston.
Great. Well, thank you so much for inviting me today and for letting me talk to you about the role of Hsv Serologies in our clinical care. Here are my disclosures. I am an affiliate in the Department of Laboratory Medicine at the University of Washington, and they are the provider of the University of Washington Western Blot Test, which I'll be talking about. And I do receive funding from the National Network of STD Clinical Prevention Training Centers. So there's no question that genital herpes has a huge worldwide impact. It is the leading cause of genital ulcer disease worldwide, and you can see 2 examples of mild disease and more severe primary recurrence here. In its most devastating form, it can cause neonatal herpes, and both genital and neonatal herpes are caused by HSV types 1 and types 2. HSV2 also increases the risk of HIV acquisition 2 to 3-fold. It really promotes the HIV epidemic in high HSV2 prevalence settings. In the United States, we've seen a declining trend in HSV seroprevalence, both for HSV1, shown here in red, in men and women, and also in HSV2, shown here in black, which has been more predominant in women. And it should be noted that women do bear the brunt of HSV2 infection with about a 2-fold increased seroprevalence compared to men. But in 2015, overall, the HSV1 seroprevalence in the United States was 47.8% of people, and HSV2, 11.9%. So quite prevalent infections. In terms of the clinical spectrum of HSV2, really the minority of people have recognized symptomatic infection. It's estimated only 20% of those who are infected fall into that category. Another 20% actually appear to be asymptomatic, but most people with HSV2 infection are actually undiagnosed. They may have mild symptoms or may not have seen a physician or a primary care provider at the time that they had a lesion and really do not have a clear diagnosis of HSV infection. And that's where serologies can be important. Why should we diagnose genital herpes? Well, it is a high prevalence condition, and most HSV2 seropositive persons are symptomatic, but they don't recognize their symptoms as such. Transmission can come from undiagnosed persons, so there's a real prevention aspect to knowing if you have genital herpes. And importantly, patients really want to know their status. Patients are often coming in and asking for HSV serologic testing. HSV serologic testing can also have implications for pregnancy management. So it is important to make a clear diagnosis of genital herpes. I'm now going to talk about some of our serologic testing strategies. We can test for IgM, we can test for IgG, both as a diagnostic or a screening methods. And I'm going to talk about the complexities of IgG testing. So IgM testing has long known to be neither sensitive nor specific for diagnosis of primary genital herpes or recurrent genital herpes. And it's not recommended in the CDC STD guidelines or by a variety of other organizations. In addition, it's not type specific, so you can't tell with an IgM test if you have HSV1 or HSV2. And there's a really nice recent study from Mayo Clinical Laboratories, which is a reference lab, that looked at their HSV testing over a 3-month time frame. And they found they had over 22,000 HSV tests ordered during that frame. But 20% of tests were IgM only, and IgM serologic testing was included in over half of the HSV-related testing. And when they looked at the times when IgM and HSV PCR, meaning there was probably a clinical lesion present, were ordered, 50% were positive only by RT-PCR, and a rare minority were positive at all by IgM. So this test was neither helpful clinically and was massively overordered. And in response to that, Mayo Clinical Laboratories, after reviewing these data, actually discontinued their IgM testing. And I would encourage you, if IgM testing is still offered in your setting, to let your lab directors know about these issues, and definitely do not order IgM testing for HSV serology. Now, we do have HSV IgG testing that does have an important role. The IgG testing is based on antibodies, detecting antibodies to these envelope glycoproteins. And the main one that is used for ELISA tests and our commonly used tests is antibodies to glycoprotein G. The Western blot and some immunoblots detect several antibodies to different glycoproteins on the surface. These glycoprotein tests are important because they are type specific and they can differentiate between HSV1 and HSV2. So let's go through another case. This is a 32-year-old cisgender woman who has a history of 8 lifetime male sexual partners. And she's coming to you with occasional itching in the genital area, which occurs 2 to 4 times a year. And the symptoms usually resolve within a 3-day period. She has just self-treated these episodes for vaginal candidiasis. But during one episode, she did seek care and was told she had a sore that looked like it could be resolving genital herpes, but an HSV culture at that time was negative. And at the time of your visit, she does not have symptoms and her genital exam is normal. So is this someone who should be tested for HSV2 using serologic testing? And the 2015 CDC Std Treatment Guidelines suggest, yes, this is a perfect person to test for HSV. HSV type specific serologic testing is indicated for a diagnosis in someone who has recurrent genital symptoms or atypical symptoms with a negative HSV PCR or culture, or someone who's coming with a clinical diagnosis of genital herpes without lab confirmation. In addition, someone for whom you have a high pretest probability of infections, such as someone who has a partner with genital herpes, would also be a candidate for Hsv serologic testing. So here's another case of a 25-year-old cisgender man who's anxious that he has genital herpes. He has been looking on the internet quite a bit and worried about acquiring this. He has 2 lifetime cisgender male partners. He's always using condoms and has no history of genital symptoms and no history of STIs. So is this someone who should be tested for HSV2? And this is a case of asymptomatic screening for which testing is not recommended. The U.S. Preventive Services Task Force reviewed these data just in 2016 and again recommended against screening for HSV2 infection among people who are asymptomatic, including adolescents and adults. And given the limitations of the serologic testing, which I'm going to go through in a minute, I agree strongly with this recommendation, especially for people with low pretest probability of infection. In addition, several groups recommend against the serologic screening of pregnant women, although you should screen pregnant women for a history of genital symptoms, which could suggest genital herpes. So in this case, the patient was diagnosed with HSV2 after being tested by his primary care provider. The type-specific HSV2 ELISA test had an index value of 1.5, and he was HSV1 seropositive. So now I'd like to take you through how to interpret these test results. So first of all, what is an index value? The commonly commercially used tests are typically ELISA or CLIA tests that produce an index value. And this is an indication of the strength of the response to the Hsv Igg protein. So with an index value of less than 9, you'll get a result of negative. 0.9 to 1.1 is indeterminate, and greater than 1.1 is considered positive. However, we know that in the real world, the Herpes Select and other ELISA tests do not perform very well. This is most recently a retrospective study of 864 patients who had an HSV EIA, followed by a University of Washington Western blot, which was the gold standard. And there were large issues with the test results. For HSV1, only 70% of people who tested positive actually had false negative tests, although the test was specific. And for HSV2 infection, there was good sensitivity, but very poor specificity. And when they broke that down by index value, you can see here an index value of 1.1 to 2.9 only had 40% specificity, so worse than flipping a coin. And even with higher index values of greater than or equal to 3, there was only about 79% specificity. We know that false positives are more likely at these low index values and in persons with HSV1 infection. And this study reaffirmed that finding as well. So the 2015 CDC Std Treatment Guidelines did recognize that the Herpes Select may be false positive at low index values, and actually did recommend confirmation with a second test, either a BioKit or the Western blot. The BioKit is a point of care test that could be high throughput and inexpensive, but it's rarely reflexively performed. And the UW Western blot is available, but only from University of Washington, and it is quite a laborious process for patients to track down the lab test, get it sent out, and it often isn't covered by insurance, and the cost is borne by the patient. And one thing we don't know is whether labs are even adhering to these guidelines and whether providers know about this complexity of testing for HSV serology. We also know that many other ELISA and CLIA tests are used commercially, and we don't know the test performance characteristics of these tests. And many of the approved tests were compared to the Herpes Select, which has all the issues I just laid out for licensure. And an infectious disease fellow from University of Washington, Dr. Abby Hussein, will be presenting some of the data to learn more about this. And please visit poster 2150 to see more information. As I mentioned, we don't know much about test characteristics for other HSV2 immunoassays, but this was a nice study that came out within the last year that looked even at index values of greater than 3.5 when compared with an inhibition assay, which is another way to test for HSV activity. 20% of the herpes select cases above 3.5 were false positive, and 40% of the liaison were false positive. And that is a test that is commonly used as well. So we really have issues with our testing. And importantly, these test results have huge impacts for patients. There have been a couple of great articles in the last year or two showing and discussing the flawed herpes testing and how it does lead to false positives and suffering, and as well how it contributes to stigma associated with herpes. And I can tell you that my inbox is full of patients testing, not understanding their results, doing their own research, desperately trying to get a confirmatory test. So we really have an issue here. What about HSV-1 serologic testing? I just want to say a quick word about that. This is a highly prevalent infection. As mentioned, about half of the US adult population has this. The HSV-1 serologic testing can't differentiate between genital and oral infection. And as I showed, it has poor sensitivity. And it really is rarely useful in the STI setting. So in conclusion, it is imperative to use accurate diagnostics when making a diagnosis of a chronic viral STI, such as HSV. And ideally, we would have a testing strategy that would inform patients of their HSV status without confusion. And it's been proposed by Dr. Ned Hook and others that we look at or think about a two-step testing strategy for HSV2 serology, similar to what we do for syphilis testing. We would never give someone a diagnosis of syphilis without knowing both their RPR, treponemal and non-treponemal testing. And I wonder if we should go that way for HSV as well. We also desperately need improved serologic tests with better specificity for HSV2 and better sensitivity for HSV1. So my take-home points, please don't ever order HSV IgM testing. It is not helpful and it will not help you in your case. Use HSV serology, IgG, as a tool for diagnosis, but not for screening, and follow the U.S. Preventive Services Task Force guidelines. Know which test your lab uses and know what the test characteristics are of that test. And please check the index values and know when additional confirmatory testing is needed if your lab is not doing reflexive testing for you. I'm happy to take any questions at any time, and my email is shown there. Thank you very much.
Now I'm happy to introduce Dr. Susan Tudenham, who's an assistant professor in the Division of Infectious Diseases at Johns Hopkins University, where she completed both her residency in internal medicine and her fellowship in infectious diseases. She's a clinical STI expert who heads an infectious diseases clinic focused on vaginitis and recurrent urinary tract infections in women. Her research interests are in sexually transmitted infections, vaginitis, and the human microbiome. Dr. Tudenham has recently been elected as a junior board member of the American Sexually Transmitted Diseases Association, and she served as a subject matter expert for adult syphilis for the CDC Std Treatment Guidelines. Dr. Tudenham will be speaking with us today about treating resistant BV.
Thank you, and I'm delighted to be here today to speak to you about treating recurrent bacterial vaginosis. These are my disclosures and acknowledgements. So we'll start off today with the case. This is a 25-year-old African-American woman who's coming into my vaginitis clinic at Johns Hopkins complaining of recurrent vaginal symptoms, including odor and discharge. She's had antibiotics 7 times in the last year. These episodes began about a year ago. She was in a monogamous relationship, then ended that relationship, had a couple of new male partners, and she's now been monogamous with 1 male partner for the past 11 months, but she continues to have these recurrent episodes. She thinks they might be triggered by menses and possibly by vaginal sex, and today is no exception. She's complaining of vaginal odor and discharge for the past week. She uses condoms intermittently, no other forms of contraception, and she smokes about a half pack of cigarettes per day. She's had recent STI testing, which was all negative. So on exam, she has thin, homogeneous, whitish vaginal discharge, an elevated vaginal pH, clue cells more than 20%, and a positive whiff test. So she meets 4 out of 4 of the AMSLS criteria, and I diagnosed her with recurrent bacterial vaginosis. But this patient does a lot of reading. She looks up questions on the internet, and she has some very specific questions. So she's asking, what medication options do I have? Is there a different antibiotic I can take for this recurrent BV? Is there anything at all that I can change to get rid of this recurrent BV? Should I, I've read a little bit about hormonal contraception. Should I get onto some sort of hormonal contraception? And if so, what kind? And what about boric acid? I have read a lot about this on the internet. I have some friends who are using it. Is that an option for me? Lastly, what about probiotics? I see a lot of probiotics advertised for vaginal health. Should I be using a probiotic to treat my recurrent BV? So we'll go through her questions in the course of this lecture, talking about options for recurrent bacterial vaginosis. So just for a moment to step back and define the condition, as you're aware, in the optimal or healthy state, the vaginal microbiota, or the communities of bacteria living in the vagina, are dominated by lactobacilli, which, as their name suggests, they produce lactic acid. In some women, for reasons that are incompletely understood, lactobacilli are decreased and are replaced by an overgrowth of a variety of organisms, mostly anaerobes, including some of these which are listed above. This condition is bacterial vaginosis, and it affects about 30% of US women. 45% of those are symptomatic, generally complaining of vaginal odor and discharge. It's diagnosed via AMSLS criteria, which I went over with the case patient, also via Nugent score, which is based on a gram stain. And there are a number of new molecular, some of them somewhat microbiome-based diagnostics that are becoming increasingly available. BV treatment is recommended for women with symptoms only and consists of oral or intravaginal metronidazole or clindamycin, with options also for oral tinidazole and a single-dose oral secnidazole option, which was approved in 2017. So all of these regimens have roughly equivalent efficacy. There's not one that's really better than another. But the issue we're really going to focus on today and the problem is that BV has very high rates of recurrence. So nearly 30% of patients will recur within a month and 60% within 12 months. And then there are a subset of women who you may have seen in your clinics who recur repeatedly and really relentlessly. So almost no sooner are their antibiotics completed, but it seems that the BV comes back. And for some of these women, they unfortunately also frequently develop secondary vulvovaginal candidiasis as a result of the BV medications, which can be very difficult to deal with as well. What factors are associated with BV and with recurrent BV in the literature? Well, multiple studies have shown an increased risk of BV in those with new or multiple male partners. And conversely, there seems to be a decreased risk of BV in those who are using condoms. In women who have sex with women, having a female partner with symptoms is highly predictive of BV in the index patient. So there's a lot of concordance between female partners. The data is perhaps less robust, but there are a number of studies that suggest that smoking is associated with an increased risk of BV, and douching as well, although there are some studies that don't necessarily show the relationship between douching and BV. Some studies show that there is an association between decreased incident and prevalent bacterial vaginosis in women using hormonal contraception. And lastly, in some of the male circumcision studies that were done for HIV prevention, there's a suggestion that male circumcision actually decreased BV in the female partners. So we see these factors associated with BV, but really, why is recurrence happening? Why is this such an intractable issue? And I would say this is an area with a lot of interest and a lot of active research, but few definitive answers. I think the thoughts about why this is occurring center around two possibilities. One is that of reinfection or reinoculation. So perhaps the woman with BV is getting treated, but maybe there are BV-associated bacteria colonizing their partner, or perhaps a fomite like a sex toy. And so they keep getting reinoculated with this bacteria, and that's part of why they keep getting recurrent BV. I will say that thus far, male treatment trials have not resulted in decreased recurrent BV for the female partner, although there may be some methodologic issues with those trials. What about relapse? That's another possibility that there's a lot of research on and interest in. including on the possibility that there may be bacteriophages that could potentially be sexually transmitted, destroying lactobacilli. There's a lot of really important and I think interesting research on the possibility that a biofilm forms in recurrent BV, perhaps as a result of individual bacteria or multiple bacteria acting in consort. And this means that it may be very difficult to eliminate the BV-associated organisms completely. Those residual bacteria can then serve as a seed leading to relapse. So there's a lot of interesting work being done on that possibility. Lastly, I think part of the issue and why we are not very successful in permanently treating recurrent BV may be that the tools we are working with are relatively blunt. So our main tool to treat BV is antibiotics, and with those we are able to knock down the levels of BV-associated bacteria. But ideally, probably we would not only want to do that, but we'd also like to recolonize or reintroduce healthy and protective lactobacilli, especially those like Lactobacillus crispatus that we know are good at making lactic acid and are associated most strongly with positive reproductive outcomes. But back to your case, that's some research and some ideas as to why recurrent BV might be a problem, but what can you offer her practically right now based on what we know about recurrent BV? And just as a reminder, this is a woman who truly does have recurrent BV, defined as at least 3 episodes per year. The truth is that the options for her are very limited. She asked about behavioral interventions, and I think it's certainly reasonable to talk to her about using condoms with her male partner. Again, the large studies have shown that association between condom use and decreased BV. So it's not something reasonable to discuss with her as a potential behavioral intervention to see if it might help. Douching, I think for multiple reasons, not only relating to BV, is not a good idea. Now the data are a bit plus minus, so I never promise women that if they stop douching, their BV will go away. But I think for multiple reasons, it's a reasonable thing to discuss not to do, not to douche. This patient is not douching, so it's not going to help her. What about smoking? Again, I think there is no study that has been done prospectively to say that if you stop smoking, your recurrent BV will get better. But I think, again, for multiple health reasons, counseling this patient on smoking cessation is reasonable. In terms of antibiotic options, and she asked you about this, I think the first thing that we generally try is to use a different recommended treatment regimen. As I mentioned, these regimens all head-to-head have similar efficacy. But anecdotally, sometimes, for example, if a patient has only been treated with metronidazole in the past, treating her with clindamycin may result in a longer period free of symptoms. So again, this is anecdotal, but it's recommended in the STD treatment guidelines and by experts, and it's worth a shot as a first try. If this fails or you can't use that, or if they continue to have recurrences after that, as per the CDC Std Treatment Guidelines, there are a couple of suppressive regimens that may be an option. So the first involves treating with an oral or intravaginal nitroimidazole for about a week for an acute episode, and then transitioning to intravaginal metronidazole gel or Metrogel twice weekly for 4 to 6 months as a suppressive regimen. There's another regimen that's in the guidelines that involves doing something similar, but treating during the period that you're treating acutely for the BV episode, also with 600 milligrams of intravaginal boric acid for 21 days, and then transitioning to the suppressive Metrogel. It's important to note that boric acid can be fatal if taken by mouth, and there are questions about fetal toxicity and teratogenicity. So women have to be well counseled only to use this intravaginally and to use reliable contraception. And lastly, there's another option mentioned in the guidelines of monthly oral metronidazole with fluconazole. Now, I won't go into all the data behind these, but for the 2 main metronidazole suppressive regimens, these are based on studies done by Dr. Sobel. The first Metrogel suppression regimen without boric acid is based on a randomized controlled trial where women after treatment for BV were randomized to 16 weeks of suppressive Metrogel versus placebo. And basically, while they were on this, it did seem to be fairly effective in suppressing recurrent BV episodes. So at 16 weeks, at the end of this 16-week treatment, 70% using the Metrogel were cured versus 39% of those using placebo. Unfortunately, the BV recurred pretty quickly after the Metrogel was stopped. And so at 28 weeks, only 34% remained cured in the Metrogel arm. Also, about 40% of these women using Metrogel had an episode of vulvovaginal candidiasis. In terms of boric acid regimen, this was based not on a randomized control trial, but a pilot one-arm study. It seemed like about a similar percentage, about 65% were cured at 28 weeks while on therapy, about 50% cured at 36 weeks, but again, very hard to compare the two of these because this was not a randomized control trial. So the next question that the patient asked you was, can hormonal contraception help? And I think the short answer is we need more information. But one question she asked was, what kind of hormonal contraception should I get on if I'm getting on a kind, if I'm interested in starting hormonal contraception? And I think one question is if there's a potential benefit, and I did mention that the overall studies may show an association between decreased BV and hormonal contraception use, are progesterone-only contraceptives and combined estrogen and progesterone contraceptives the same in terms of a potential positive effect they might have. Multiple studies do show a reduced risk of incident and prevalent BV in combined hormonal contraceptive users. And a meta-analysis also showed decreased incident and prevalent BV with progesterone-only use, although if you actually look at the studies, relatively few of them showed on an individual level a statistically significant difference. Moreover, since that meta-analysis came out, several recent studies have not really shown a positive impact of progesterone-only contraceptive use on the vaginal microbiota. So I think it's an open question. I think there's a great deal of interest, particularly in the combined estrogen and progesterone contraceptives and whether these might help women with recurrent BV. So there was a pilot study that was done out of Australia where women with recurrent BV were randomized to start oral contraceptive pills versus controls who just continued with current non-hormonal practices. There was no difference in recurrent BV in these groups, but the sample size was very, very small. So only 26 women in the oral contraceptive group. So I think ultimately we need more data. Lastly, some experts will suggest removing IUDs in women with recurrent BV, but again, we need published data to support that recommendation. So I think the short answer is we don't know. Perhaps there's a suggestion that combined estrogen progesterone contraceptives might be a little better, but we need more data to be able to say if this is helpful in women with recurrent BV. There are some new therapies for recurrent BV on the horizon. So there's a product, TOL 463, which is an intravaginal product containing boric acid and EDTA, not commercially available yet, but there was a phase 2 trial of using this to treat acute BV and acute vulvovaginal candidiasis, and it had some efficacy, about 50 to 60% clinical cure rate for BV, although a larger percentage of women did report symptom resolution. And speaking of boric acid intravaginally is something that's been commonly used both by clinicians and by patients for a very long time, but there's very little data on its use. So we published last year for the first time just a description of clinicians' use of intravaginal boric acid in a suppressive way for treatment of vulvovaginal candidiasis that's recurrent and recurrent BV. And most of these clinicians we found use sort of an induction regimen of daily boric acid, usually 300 to 600 milligrams for 7 to 14 days, followed by twice weekly intravaginal boric acid. But this was a very descriptive study. We really didn't have data on outcomes. And so ultimately, we need prospective studies to understand if this regimen is working at all in preventing recurrent bacterial vaginosis, and if so, how effective it is. I did note that there may be a trial of TOL 463 used for suppression in women with recurrent BV starting. So perhaps we'll have more data on this soon. Lastly, I think something that's really interesting and new in the field is that in just this year, there was a study published in the New England Journal of Medicine by Cohen, which involved a probiotic. So this was a lactobacillus probiotic intravaginal to prevent recurrence of bacterial vaginosis. And it did show some efficacy. So by week 12, those receiving the lactobacillus crispatus probiotic had 30% recurrence. Versus placebo had 45% recurrence, and that was statistically significant. So perhaps only in the terrible world of recurrent BV would we be excited about a 30% recurrence rate, but I think it is exciting, and as proof of concept, it's very interesting that and encouraging that hopefully we'll be able to develop probiotics to help treat women with recurrent BV in the near future. Lastly, I'll just mention, you've heard of FMT. Well, last year there was the first report of a vaginal microbiota transplant, just 5 women, but to treat recurrent bacterial vaginosis. Clearly we need more data, but this is a very interesting area of inquiry. So back to your patients, just to wrap up and her questions. I think before we go through her questions, first of all, it's very important to sort of set expectations for management of recurrent BV in these patients. I think effecting a quick and permanent cure may not be realistic, so you try to discuss with them that this may be a longer-term management issue. But with regards to her questions, what medication options do I have? Well, you can switch medications. If she's, for example, been treated with metronidazole only, try treating her with clindamycin. And then if this fails, try doing Metrogel suppressive regimens. Is there anything I can change behaviorally, she asked. Certainly you can talk to her about condom use. You can suggest not douching or not smoking. No definitive evidence, but for multiple reasons, those are probably a good idea. Should I get onto some sort of hormonal contraception, and if so, what kind? Well, there is some suggestion in the literature that hormonal contraceptives might be beneficial, and perhaps an idea that combined hormonal contraceptives are more beneficial than progesterone only, but ultimately we don't know. The data isn't there. And so I think choices regarding hormonal contraceptive use and type should be guided by patient preferences for contraception first over secondary BV concerns. So if she wants to start hormonal contraception for other reasons, great, but we need more data on this. What about boric acid? Somewhat similarly, I think it's commonly used, and we do sometimes use it in these patients, but more data are needed. We need prospective studies to really tell us if this is efficacious in preventing recurrent BV, and if so, how efficacious. Lastly, what about probiotics? Well, I think there are no currently available options with adequate data, and of course, probiotics, as they're currently available over the counter in drugstores or in pharmacies, or over in the supermarket, are not FDA regulated. So there are no current options that I could recommend for her right now, but there are options under development. And I think that some of these may really hold promise for the future. So this patient, I ended up treating her with clindamycin. She did ultimately relapse. And so we started her on Metrogel suppression, and she's been doing very well on that for the past 4 months. I want to acknowledge Khalil Ghanem, my principal mentor, Anna Powell, also Rebecca Brotman and Jacques Ravel from University of Maryland, and most of all, Dr. Jack Sobo, who's been so patient with answering so many of my questions about recurrent BV. Thank you very much, and I'm happy to take questions.
Thanks to everyone for attending this panel, and please join us on Friday, September 18th at 3:30 Eastern for a Q&A session.